Welcome, CTO Demonettes. Welcome back to the channel. Those who follow the channel knew that last week I published a video about the 10 pet peeves for coronary angiogram. As you know, as a CTO operator, I also spend a lot of time teaching juniors, first year trainees, second year trainees to do coronary angiogram. And there are things that really frustrate us. And so I put out 10 pet peeves. Of course, you can all guess what's coming next. Most of the time, I'm not teaching people doing coronary angiogram. I'm teaching them to do reverse cart or to do CTO. And so, of course, after the 10 pet peeves for coronary angiogram, here comes the 10 pet peeves for CTO proctoring. I think a lot of CTO proctors out there are going to find these really close to their heart. So here are the top 10 pet peeves when I'm proctoring a CTO. Number one, the operator is not realizing that the wire is way out of the vessel architecture. Now this is, I admit, unfair comment because it takes a certain amount of experience to know what's inside the vessel architecture and what's outside the vessel architecture. But I see a lot of juniors, they're wiring and they will say, oh, this is in a side branch. It's in a side branch, it's still in the vessel architecture, and they're fooling themselves because there's no side branch that goes so far in between two branches that are so big, like this example. So this circumflex CTO, you can see here, and they wired, and they say, oh, this is inside the vessel architecture. Let's put a balloon down and balloon it. I say, well, no, not really. This is a far way to go. Now, they can go outside the architecture because they keep pushing very far before they check an angio. And very often, they don't have a good idea of where the vessel is, and they need repeated angios to see where the vessel is because their brains haven't been trained yet to know where the vessel is lying. Their memory is not so good. And yet, this comes to my second point, they never use a roadmap. What frustrates me is they don't use a roadmap. Now, sometimes I do a lot of cases overseas, and sometimes in some lab, they don't have a roadmap function. There is no screen for you to put up a previous angio that you can compare with. And I find that quite disconcerting. Sometimes I feel a little bit lost when I'm beginning to do a CTO and there's no roadmap. But after a while, you kind of go to the no roadmap mode and you cope with it. But especially for beginner operators, a roadmap is very important. That's how you train your eye to see. But what frustrates me is that they don't even make a roadmap, or even if they made a roadmap, they don't put it up. Even if they put it up, they don't look at it. I mean, you've got to take 3 steps. You've got to make the roadmap, you've got to put the roadmap up, and then you've got to compare carefully with where your wire is to the roadmap to be sure that your wire is still in vessel architecture. But sometimes they just don't do that. And so these two, number one and number two, not realizing the wire is outside the vessel architecture and not using a roadmap is my top 1 and 2 frustrations, my pet peeves. The reason is this is dangerous because it's okay to go out of a vessel architecture with a wire as long as you come back with it and correct yourself. But if your vessel is out and you start cracking devices down, or you start wiring this vessel very roughly, it's going to cause a bigger hole and going to cause tamponade. So that's not good. Now, while I'm at this, I'm going to talk about rough wiring. And rough wiring isn't in my top 10. It's not even in my top 100. And some people, you look at them and some operators, they wire very roughly. I mean, Bill Lombardi, you look at him do case, the wire is very rough. But that doesn't irk me at all. I have no peeve with that at all because most of the time he's wiring inside the vessel architecture. You can be as rough as you like if you're inside the vessel architecture. What I don't like is when you're clearly exiting the vessel and you're treating the wire rough. And this is not the tip of the wire, it's the shaft that's you're pulling it back and forth, and it's grinding this hole that you exited into a bigger and bigger hole because then you get tamponade. So that's what sort of is my pet peeve. Number 3, I think this is a top pet peeve for most CTO proctors, not willing to try the suggested technique. When I tell them to knuckle the wire, they don't want to knuckle the wire. They keep trying to use a single wire going down. When I tell them to put a stingray balloon down, they don't want to try it. When I try to go retrograde, they don't want to try the channel. They have an opinion that this channel is too difficult and it's not possible. Well, it's a bit disrespectful to me. I mean, if you ask me to be a proctor, I have done more CTOs than you. I have a bit more experience. I've written a bit more about it than you have. So you should listen to my advice. But I'm willing to try a technique means you're stuck and the case just doesn't move forward, and the proctoring doesn't move forward, and your learning doesn't move forward. It stalls everything, and it's extremely frustrating. Number 4, this is an addiction, and I understand and I sympathize and empathize with people with addictions, but there are some operators that have contrast addiction. They got to keep flushing contrast for no good reason at all. Now, this is problematic in PCI because you're wasting contrast. It's very problematic in CTO PCI because contrast limit is one of the limits you have for your case, and if you keep flushing contrast, you're just wasting contrast. And sometimes it's in a really bad situation. You've done an aggressive reverse cut, and they still insist on flushing antegrade contrast and causing the hematoma to be bigger and bigger. You tell them there's already a hematoma, and they can't stop themselves. They've got to keep flushing contrast and keep injecting contrast. They've got this contrast addiction. They've got to see contrast to be happy. Oh, this is very difficult operator to proctor, and sometimes I just take the syringe off and throw it away so that they can't inject contrast. I have no other option. Okay, so number 1, not realizing the wires outside the vessel. Number 2, not using roadmap. Number 3, not willing to try suggested technique. Number 4, contrast addiction. Number 5, ignoring hypotension. This is very bad because if you ignore hypotension, patient is going to get worse and worse. I mean, there's a very extreme case a long time ago now. I was a junior, so nobody listened to me, but the operator was doing a case and the blood pressure was going lower and lower. It was 90, 80, 70, 60. But he was making progress with the CTO. He was getting through the CTO and was ballooning it and he's starting to stent it. When he finished and he took an injection, there was no flow down the coronary, not because the coronary was obstructed, but there's no aortic flow anymore. The aortic valve was closed. The patient had arrested. So of course, then he did CPR, and luckily the patient survived. But ignoring hypotension is just not the way to go. You need to sort out the hypertension for the patient. So that's something that is a pet peeve because it endangers the patient, and it makes me feel very uncomfortable. Number 6, losing wire position. I'm sure any proctor is going to go, oh, I feel you, mate. I feel you. I feel your pain. So only this week, I was proctoring a guy and a long RCA CTO, but it has got this long PLV that's normal after the CTO. And so he managed to get through with an XDA, and you could put the wire really down so far, all the way down the apex. They've got about 90 millimeters of normal PLV to do work on. And already you can see he's using a guide extension. He's got great support. And the wire comes back, not 10 millimeters, not 20 millimeters, not 40 millimeters, not 60 millimeters, not 80 millimeters, but 125 millimeters. And he loses wire position and he can't wire back down. And so he has to go back down with a microcatheter, do an XTA exchange and wire again the CTO and come down. Not so lucky all the time. Sometimes you completely mess the case up. But losing wire position really is the most painful thing for a CTO proctor. I hope you feel my pain and sympathize with me. Number 7, not willing to use a strong guiding. This is extremely painful. People insist that you're not allowed to use AL guides or even a hockey stick for an RCA CTO. I was once in a center doing a case where somebody had failed before. The guy who failed was a famous Japanese operator who was a very good operator. He's already used an 8 French AL2 to engage the RCA with an anchor balloon in the conus branch, and he couldn't pass anything antegrade. The operator says he didn't like aggressive guides, so I was allowed to use a JR 7 French. That's hopeless, you know. I mean, your hands are absolutely tied behind your back when it's supposed to be proctoring the person decides that you're not allowed to use a guiding. So that's very painful. Along with this, not willing to adopt techniques to improve your backup support. I put it under the same thing, number 7 still. So sometimes you ask them to use the side branch anchor and they don't want to do it. You ask them to use a coaxial anchor to anchor across there and they're not willing to do it. Whatever you ask them to do that increases backup force, they put, and everything they do is backing. And they only want to exchange wire for sharper wires. And you have less and less backup support for sharper and sharper wires, and it becomes very dangerous. So that's a pet peeve. And then number 8, putting the pericardiocentesis drain in the right ventricle. Okay. This is a pet peeve because usually when you're trying to do pericarditis, the patient is very, very ill, and making another hole in the RV really is not good. So I really encourage everybody, even if the patient is crashing and it's dangerous and you're rushing and you're filled with adrenaline, just to check where you are with your wire. Push the wire out so that you get a nice surrounding wire of the ciliary head. You're sure you're in the pericardial space, or even put a little microcatheter in and just do an injection and make sure you're in the pericardium before you change out for a big sheath. Because what's worse than 130 millimeter hole in the heart is 230 millimeters hole in the heart. So you don't want to create another hole in the right ventricle if you can help it. Number 9, refusing to do pericardiocentesis. I'm very fortunate that that has not happened to me. So this is an imaginary scenario. Every time that I've had a patient that requires pericardiocentesis during CTO proctoring, the operator has been willing to do pericardiocentesis, or at least willing for me to do the pericardiocentesis. I've not been stopped. But I can imagine that will be extremely frustrating, watching a patient being more and more hypotensive, waiting for surgeons to come to open a window. That's horrible. And number 10, okay, now what's the big number 10? This is the big pet peeve for me, and that's not having the equipment, but going down the road towards that equipment. I was once in a center, and I was there to proctor for Stingray device. I was invited by the company that owns Stingray to proctor for Stingray. And we arrived there, and we are doing the case, and we knuckled down, and we ballooned it, and we put down the Miracle 12 wire through our turnpike catheter, and we take the turnpike out, and I said, Stingray balloon, please. And they say, no Stingray balloon in the cath lab. They have just not organized to deliver Stingray balloons to the cath lab. So now you have a subintimal space with a Miracle 12 without a Stingray. And this is in a country that doesn't have a CTO-specific IVUS, or even an IVUS that can pretend to be CTO-specific. That was terrible. So a lot of conquest wires to try to fenestrate it, but it was not successful. But so not having the equipment when you're going down that road is kind of a disaster. It's kind of like doing retrograding. You not have an RG3 when you get through. That's really is a stinger for the CTO proctor. So that's my top 10 pet peeves. Not realizing the wire is outside the vessel, not using rope map to make sure that doesn't happen, not willing to try out suggested techniques, contrast addiction, ignoring hypotension, losing wire position, not willing to use backup force, not be putting a pericardiocentesis drain in the RV or somewhere else, refusing to do pericardiocentesis, and not having the equipment when we've been going down that road for the last 45 or 60 minutes. So I hope you learned something from this. If you're a CTO operator and you feel great pain and empathy with me, if you're a CTO proctor and you feel my pain and we share this pain together on the channel, it's good to share pain, you know. And I hope that we don't make these mistakes, whether we're doing the procedures ourselves or whether we're proctoring others. We'd be more fluid and flexible and willing to take up new techniques, willing to use stronger backup force, and with all that, have greater success in our CTO cases. All the best luck with your CTOs. We'll see you next time. Bye-bye.